people who are kind of now got their feet wet with procedures, they're exploring new devices, say they're considering getting laser or other atherectomy, or considering starting the trial or getting, like, what kind of advice do you have to people who's just kind of listening to this podcast right now and thinking like, oh man, like I want to get better outcomes and better treatment algorithms for my patients? I mean, what would you say to them?
Oh, I would say awesome. So do I. And let's team up and do it. And I would say,
Yeah.
let's totally get away from kind of the like slashing at each other. And, the public does not understand the difference between a vascular surgeon and interventional cardiologist. And I just had my hair done yesterday, and the lady who's doing my hair literally was like, oh, I said I'm a vascular surgeon. And she's like, cardiology. She actually said it. So like, and of course I can't. And then at the end of that, all she got from that was I do hearts and veins, which I do a little bit of veins. I don't do any hearts. So like, but I think we as a group need to say, let's like come together. So the people out there who are listening about that, we're all on your side. And I think this next group coming up, if we don't do something about it, we are going to suffer it. We're going to be the ones getting 2 a.m. calls because what we spent 6 hours taking care of went down. Where our patients are going to be not satisfied because they're going to go through all this garbage and it's not going to last. We're the ones that are, and as you all know from doing these procedures, every time you do it, it's harder and harder and harder. So, I think a lot of us got into PAD, myself included. One of the reasons I like it so much is I like the absolution of it. With aorta, a patient comes in with an aneurysm, they don't even know they have it. Then I tell them they have this horrible thing and I fix it, but they never felt bad. With PAD, you got people who are like decrepit and lives are being ruined. You fix it, their wound heals, and they get their lives back. And I want to continue to do that. But because the patients are getting sicker, it's getting harder to get to that point nowadays. And so I would say to those people, don't lose hope, join forces, and let's do it. Like, what are we talking about? Let's do it.
I love it. Let's do it.
Let's do it.
Let's do it. Well, great. I mean, thanks. I will bring up the question. I don't know if you had time to think about it, where what is, your most underrated and most overrated device in your tibial intervention? And then we'll wrap up the episode. So any thoughts, you can comment on it or not, but what do you think?
Underrated device in tibial intervention, I think I'm going to say, honestly, deep venous arterialization, like the kick, like lymph flow. And the reason I'm going to say that is because it really is in the patients that are, again, appropriate patients. That's always the name of the game. Absolutely, 100%. There's data everywhere now. And there's durable data 2 years out that in the right patient, 100% it saves the legs that otherwise would have been amputated. I'm a believer anecdotally. I'm a believer from the data. I do not get paid by that company. But I'm just saying I really think, and people, kind of are coming at it for the worst of the worst, like saying, oh, when the patient has a wound and like we're thinking of amputation. And you shouldn't. You should actually do rest pain, in my opinion. A little bit earlier. Save that leg. That's super underrated. And, if you're not doing it, it's something to think about because it's really easy to do, actually, like really easy and something that's worth doing. And
it's funny. About DVA too. I agree. I think, right now we're doing it on such end stage disease. I think we're going to start seeing it becoming more, of course, not first line, but something you would go to and do before you're going to try like 2 hours on a nasty lateral plantar artery just to get like your balloon distally. And then you're like, okay, I'll balloon it finally, right? Instead of spending an hour just to get there, to do the hour and do the DVA and get so much more flow. We're seeing that too. We're doing, I'm in the boomerang trial with distal stantless, right? And we're just like, oh man, we should just start going to this sooner. Mm-hmm. So it's kind of what we're thinking. So that's a really good suggestion for a very underrated device that I think we're going to see big time. So now overrated, this one's a little bit more controversial. What is the most overrated device? I'll tell you mine. I think is like just like a normal scoring balloon, like a Vascutrack or Ultra Score, something like that. I think those are overrated, in this day and time when we have a lot more better vessel prep. I just thought like one little wire. I think there's other ones that are better, but yeah, that was something that I was thinking about. But what is yours? So I'll make it a little bit icebreaker style.
Thank you. Well, I was just going to say POBA, just general POBA. Super overrated. There's nothing wrong with it. It had its place. There was a time when it was a god, like, because there was nothing else. But like, you got to move with the times. And like, maybe in conjunction, like again, in this case, for example, the trial, sure, in conjunction with something, but to make POBA, especially because, I mean, there's data about this. That guy, remember the whole trial where the guy, he did POBA, and then he waited 3 minutes and then came back and did an angiogram, and then 15 minutes and came back and did an angiogram, and it was like, boop, like recoiled right away. And of course it is. I mean, anyone with any law, of course it is.
You see it,
Of course, you see it immediately. And
you see it while you're doing the case. Well, you've treated one tibial, you're doing the work on the other, and you look at there, you're like, oh shit.
Whoopsies. Exactly. Exactly. So, but I think, we want so bad something to work, and we don't have anything else that we have. I mean, it's human nature to overrate it, because either you can't sit there and do all this work and then say to yourself, man, I know this isn't going to work. You have to pump up and say, yep, I did something positive. And sure, it is better than nothing, but what your desired outcome is, and again, back to the DVA conversation, even if you can get around that pedal loop and balloon it, and it looks amazing on that angio, again, the point is like, your goal is not the angio, your goal is the wound healing. So there's no way that's going to last you. And even if it does, a lot of these patients are like 60 years old now. What are you going to do next year? What are you going to do 4 years from now? So if you can do something that's going to have that durability, and it's so interesting because that's the same phenomenon that's happened in aortic. Because in aorta now, it's not about your final angiogram, do I have a leak or not? Is this thing going to last, this patient, the next 35 years? Because that's how long people are living. So those are my answers, I think, for those two things.
Those are really good answers.
Thank you.